To the deep dive. Today, we're zeroing in on a really specialized role within the NHS here in the UK. It's the Clinical Coding Specialist, Divisional Lead, or CCSDL. Now, if you've pictured this as just, shuffling papers, think again, it's way more critical. This role is right at the crossroads of clinical records and, well, keeping the lights on financially for an NHS trust.
Yeah, absolutely. What's key here, and maybe not obvious, is that clinical coding, it's basically the currency of the NHS. And the CCSDL is like the bank manager for that currency within their division. They have this demanding double job, making sure the day-to-day coding is spot on accurate, but also dealing with the big picture stuff, the strategic policy.
Okay, so our mission for this dive is pretty clear then. Let's unpack why this specific leader role is the one that really decides if a hospital gets paid the right amount for the care it gives. So how does that actually work? What's the financial mechanism?
Right. It all hinges on something called payment by results, or PBR. Put simply, the NHS pays hospitals based on the type and complexity of care for each patient episode. The CCSDL's team. They're the ones who translate the clinical notes into codes, which then slot that episode into a specific payment group. And that group has a national price tag attached, the tariff.
Got it. So give us a real sense of the stakes here. What happens if they get it wrong?
Okay, well, imagine this. A patient has surgery. Pretty standard, but then there's a complication afterwards, something unexpected, maybe costly to treat. If the coder, looking at the notes, misses documenting that complication accurately with the right code.
Ah, I see where this is going.
Exactly. The whole case might get classified into a cheaper payment group, one that doesn't reflect the actual resources used. And that one error, it can mean the hospital delivered that care at a loss. Multiply that across thousands of patients.
Okay, yeah, that sounds serious. Which explains the tight controls, I guess.
Precisely. The governance is really strict. Partly it's about national health data, for statistics, HES data. But critically, for the coders themselves, there's a qualification, the ACC accredited clinical coder. And the standard for that exam, the benchmark they have to hit and maintain, is 90% accuracy.
90%, that's incredibly high.
It has to be. That's the CCSDL's core operational target. Keep that accuracy up.
So the expertise needed must be pretty intense then. This isn't just any manager role.
No, not at all. You absolutely need that ACC status. That's mandatory. Plus, significant experience. You're working with two completely different complex coding systems all the time. There's ICD-10 for diagnoses, what's wrong with the patient, and OPCS-4 for procedures, what was done to treat them. You need deep knowledge of both.
Right. Managing two dictionaries simultaneously.
Yeah, and because of that, the role becomes very consultative. It's strategic. They're not just sitting there correcting codes afterwards. They're working with clinicians, with managers, with finance teams. A big part of their job is actually training doctors and nurses to improve the quality of the notes in the first place. Better notes mean better coding.
Fix the source documentation, basically.
Exactly. Fix the notes, fix the coding, fix the funding.
Okay, let's shift gears a bit. What about the future? We hear so much about AI and automation. You mentioned automated clinical coding earlier. If AI can cut coding time, maybe by up to 40%, why do we still need this human expert lead so much?
That's the million-dollar question right now, isn't it? And CCSDLs are right in the middle of implementing this stuff. What we're seeing is a model often called human in the loop, or HITL. So the AI reads the notes, suggests the codes, but the experienced human coder, overseen by the CCSDL's standards, validates those suggestions. They check them, especially for complex cases or where the notes are a bit ambiguous. That human oversight is what maintains that crucial 90% accuracy. AI isn't quite there on its own yet for the tricky stuff.
Right, the quality control layer makes sense.
Yeah.
And is there anything else big on the horizon for them?
Oh, yes. There's a monumental challenge looming. The UK is eventually going to switch from ICD-10, the current diagnosis coding system, to the new global standard ICD-11.
Okay. And that's a big deal because
It's a massive undertaking. It's a completely different structure, way more detailed. The CCSDL is responsible for planning and managing that transition for their entire division. Think about the scale. Retraining every coder, updating systems, retraining doctors on how their documentation needs might change. It's huge. Strategic planning on an epic scale.
wow.
So yeah, to sum it up, the CCSDL is really that vital link. They translate the nitty-gritty clinical details into the language of hospital finance and policy. It's why it's a valued role, usually NHS bands 6 or 7, often with extra weighting for high-cost areas like London. They manage complexity to keep things running.
So what's the takeaway for you listening? Well, next time you hear a health statistic or read about NHS funding, just take a moment to consider this hidden layer. this incredibly specialized job focused entirely on classifying things correctly, just so the system functions and providers get paid fairly.
And maybe a final thought to leave you with.
Hmm.
Given everything we've discussed, the promise of AI efficiencies, but also this colossal task of moving to ICD-11, what level of human expertise, that human validation and strategic oversight we talked about, is truly non-negotiable? How much do we need to keep that 90% accuracy standard safe and avoid, well, financial chaos if the coding goes wrong on a national scale? Something to think about.